Welcome back to the deep dive. Today we are getting into a major disruption in gastroenterology. For years, one class of drug completely owned the space for acid suppression. But now there's a new player. It's called Vonoprazan, a potassium-competitive acid blocker. You'll hear it called a PCA. Our mission today is to figure out, why this drug even exists. What was wrong with the old guard, the PPIs, and how does this totally new mechanism solve these really persistent problems like severe heartburn, ulcers, and that stubborn H. pylori bug?
It's a really great topic.
Right.
Because acid suppression, it's just fundamental to GI health.
Mm.
And PPIs, I mean, they're revolutionary for their time, but they definitely had their limits, especially when it came to speed and, frankly, consistency. Vonoprazan isn't just a slightly better version. It's a whole new way of thinking about how to shut down stomach acid.
Okay, let's get right into that then. Before we unpack the PCA mechanism, maybe we should quickly touch on the old guard's problems. What were the main frustrations with the traditional proton pump inhibitors or PPIs?
The biggest one was probably reliability, just pure reliability. PPIs are what we call prodrugs.
Meaning they have to be activated first?
Exactly. They only become active in an acidic environment. So their effectiveness really depends on the person, and crucially, on the timing. Did you take it 30 minutes before a meal?
Right.
They also need a few days to build up to their maximum effect. And this is a big one. They often fail to control acid production overnight. That's called nocturnal acid breakthrough, and it leaves patients really suffering.
So the PPIs were finicky. They needed the right environment, the right timing, and they took a while to ramp up. So how does Vonoprazan, this PCAB, how does it get around all of that? What is this novel mechanism?
Well, vonoprazan is a PCAB, and it works by directly blocking the final step of acid secretion. It goes straight for the source, the proton pump, or H plus K plus ATPase, in the stomach's parietal cells.
Okay, so the pump is the acid factory.
Think of it as the factory's main switch. Now, PPIs would eventually bond to that switch and break it, but they needed the factory to be running to do that. Vonoprazan doesn't wait. It competitively binds to the potassium, or K plus A, binding site on that switch.
Ah, so it jams the lock before the key potassium can even get close.
That's a perfect way to put it. It wedges the lock instantly and, more importantly, reliably. It just shuts the factory down, on or off.
That distinction, instant, reliable, competitive, that seems huge. So if PPIs were like a sign on the door saying out of order, Vonoprazan is more like welding the door shut before anyone even arrives for their shift.
Precisely. And that highly targeted mechanism, it translates directly into much better pharmacokinetics.
It's a better drug performance.
Right. You see a really rapid onset of action, so relief comes fast and a very long duration of effect. You get round-the-clock control. The sources show a half-life of around 12 hours, and its oral bioavailability is about 80%, which is excellent.
And that means what for the patient?
It means quick relief, reliable control, and it doesn't matter if you took it with food or not. That addresses a huge compliance problem we always saw with PPIs.
So that reliability, that's really the bedrock for treating these chronic GI issues. Let's talk about where it's actually being used. Where is Vonoprazan changing how doctors treat these conditions?
Well, what's fascinating is that this kind of potent, sustained control makes it immediately useful across, well, all the big ones, all the major issues driven by too much acid.
Right. So the approved indications, they cover GERD, gastroesophageal reflux disease. I'm guessing especially for those tougher cases where PPIs weren't quite cutting it.
Yes, for refractory GERD, it's a huge step up. That consistency is exactly what long-term patients need for predictable symptom management.
And it's also indicated for peptic ulcer disease, right? For both gastric and duodenal ulcers?
It is. By keeping the stomach pH reliably high, it just gives that damaged tissue a much better environment to heal, and it heals faster.
Okay, but the one that seems to get all the headlines is its role in H. pylori eradication.
Oh, absolutely. This is maybe the most compelling application. You have this bacterium that's linked to gastritis, ulcers, even stomach cancer, and we're struggling with rising antibiotic resistance against it.
So how does a better acid blocker help fight a bacterium?
This is where vonoprazan is a real game changer. To kill H. pylori, you need to keep the stomach at a very low acid level, a high pH, to give the antibiotics the best possible chance to work. Because vonoprazan provides that superior, reliable pH control, the antibiotics are just more effective.
That makes total sense. You want a complete acid lockdown while the antibiotics do their job. So this is where it gets really interesting for me. We have decades of experience with PPIs. They're cheap. They're available as generics. Is the clinical benefit of vonoprazan really big enough to justify jumping that hurdle of cost and, just habit?
That's the billion-dollar question, isn't it? And the sources are pretty clear. We're not talking about a tiny incremental improvement here. We are seeing major shifts in clinical
Okay,
outcomes.
give me the numbers.
Let's look at H. pylori. The data shows Vonoprazan-based therapy hitting eradication rates in the 90 to 95% range consistently.
Wow. And PPI-based therapy.
That often lands somewhere between 80 and 85%. And with rising antibiotic resistance, those numbers are actually starting to slide downwards.
So a 10 to 15 percentage point jump in success against a carcinogen.
It's an undeniable clinical breakthrough. It's a huge deal.
That kind of difference really changes the calculation for doctors and patients dealing with an infection that just won't go away.
And it's not just H. pylori. When you look at erosive esophagitis, that's the real damage to the esophageal lining from acid reflux. Vonoprazan also shows much greater efficacy in healing.
Because of that complete lockdown.
Exactly. It gives the damaged tissue the time it needs to fully recover.
Okay, so it's more potent, it's faster. What about safety? Are we trading efficacy for new risks here?
Thankfully, no. The safety profile looks very favorable. The adverse events are generally mild, transient, very similar to what you'd see with other acid suppressants.
So the usual suspects.
The usuals: headache, maybe some diarrhea, abdominal pain, but serious side effects are very uncommon.
Now, a critical point is always drug interactions, especially if you're combining this with heavy-duty antibiotics for H. pylori. The sources point out that vonoprazan is metabolized by an enzyme called CYP3A4.
That's right. And for anyone listening who doesn't track pharmacokinetics, CYP3A4 is basically the liver's main highway for breaking down a huge number of drugs.
So if you take two drugs that use that same highway,
You meet a traffic jam. And combining it with certain drugs that inhibit that enzyme requires careful management.
like clarithromycin, which is one of the antibiotics often used with vonoprazan for that H. pylori therapy.
Exactly. Clarithromycin is a strong inhibitor of CYP3A4. So when you take them together, the clarithromycin slows down the breakdown of vonoprazan.
Which means more vonoprazan in your system for longer.
Right. And that's why you need careful monitoring and sometimes dose adjustments to avoid any potential toxicity.
What about special populations? Any warnings for children or the elderly?
Yes. For kids, it's not recommended yet. The safety and efficacy data just isn't there. For elderly patients or those with impaired kidney function, you often need dose adjustments because the drug is primarily cleared by the kidneys.
And the liver.
Also have to be cautious with severe hepatic impairment since that's where it's metabolized.
So let's connect this to the bigger picture. The success here is obviously pushing GI research forward. The industry seems to be betting big on these PCEs. What's on the horizon?
Well, we're seeing research that specifically uses vonoprazan's predictable power to go after conditions where PPIs just didn't work that well.
Like what?
A big one is functional dyspepsia. That's that persistent, really uncomfortable upper abdominal pain that doesn't have a clear physical cause. Because PCCABs offer that reliable, continuous control, they might be much better suited to manage those tricky, non-erosive conditions.
And I imagine they're also innovating on how the drug is delivered.
Oh, absolutely. A lot of innovation there. For example, they're looking at oral disintegration tablets, or ODTs, that just dissolve on your tongue.
Why does that matter more for a PCA than for a PPI?
Because the PCA doesn't need acid to be activated. It works the second it hits the bloodstream. So the faster you get it to those parietal cells, the faster the relief. ODTs, or even injectable forms for emergencies, they really capitalize on that speed.
And we're also seeing research into targeted delivery, right? Things like nanoparticles.
For sure. The idea of pairing the sustained mechanism of a PCA with a delivery system that takes it right to the target could mean, less frequent dosing and even fewer systemic side effects. It's about making the delivery as smart as the drug itself.
So wrapping this up, what does this all mean for you, the listener? I think the takeaways are pretty clear. Vonoprazan offers a superior, competitive way to block acid. It gives you predictable, round-the-clock control that doesn't depend on when you eat. And that stability translates into much better H. pylori kill rates and faster healing for serious conditions like erosive esophagitis.
And we'll end with a thought for you to consider. Vonoprazan's success comes from identifying a key weakness in that proton pump, the potassium binding site, and hitting it with a perfectly designed molecule. So given that these PC ads so reliably solve the old problems of PPIs with this instant high-efficacy approach, should we maybe start thinking of PPIs differently? Not as the gold standard anymore, but as, well, an historical treatment with a much smaller role to play in an age of superior molecularly designed therapies. That's really the question that's going to drive the next decade of GI care.